All right. I'm Aly Fitzgerald. I'm one of the residents, nephrology urology residents at Friendship, and today we'll be talking about various different literature sources, both in human medicine and vet med, associated with the perioperative use of ACE inhibitors and ARBs. Mainly, there's more literature on the human side of things, but we'll go through some papers at the end. Okay, so this is just an outline. So first we'll talk about just the RAS cascade as an overview. We'll review the main paper pre-op ACE inhibitor, um, and then we'll talk about some clinical literature analysis that I've delved into, and then also some guidelines on the human side, both from the American Heart Association and KDIGO regarding perioperative management of these drugs. We'll review systemic outcomes or systematic outcomes for both withholding and continuation in the literature, and then delve into the vet literature. So, like we all know, this is the famous cascade where angiotensinogen is produced by the liver, converted by renin to Ang1, and then further converted to Ang2 by ACE. And so ACE inhibitors block that conversion. And then angiotensin can then act on both the AT1 and AT2 receptor, and ARBs can then block the effect on the angiotensin 1 receptor. Angiotensin 2 is responsible for vasoconstriction, sodium and water retention, and then also aldosterone release. And so, like, some clinical significance that is talked about a lot in these papers is how RAS activation is really important in blood pressure control via vasoconstriction, fluid retention, and then also upregulating the sympathetic nervous system. And so then blockade of these mechanisms can then predispose a patient to hypotension. So I just have the abstract up here that we won't go into too much detail, but I did like how they put like very brief kind of synopses in all their sections, and I thought it was very clear and to the point. I just highlighted two kind of main takeaways from this paper that we'll go into in more depth, but so they found that intraoperative hypotension occurred less frequently in the omission group at 55%, compared to the continuation group where they found that in about 70% of cases. And then they found more hypertensive events in the omission group than in the continuation group. So some background, approximately 85% of human surgeries annually are non-vascular procedures, and so that's why they chose that group of individuals. And they found that it's anticipated about 13% of these cases overall are going to be patients on ACE inhibitors, and they overall just stated there's really a lack of definitive guidance in this regard as to what is the optimal management strategy for these medications before. So I've taken a couple quotes from the paper that I wanted to delve into just to give, like, kind of set the stage for background. So one of which is high quality evidence suggests RAS inhibitors are associated with intraoperative hypotension among patients undergoing cardiac or vascular surgeries. And so they include three different references. So the first one is a pretty old paper looking at the influence of chronic ACE inhibitors on anesthetic induction. So this was a small cohort of about 51 vascular surgical patients that were randomized into four different groups. So they looked at two different ACE inhibitors, captopril and enalapril. Captopril, they had a 12-hour withdraw, enalapril had a 24-hour withdraw, and then both groups had no withdraw, making a total of four. They found an enalapril, so they actually measured plasma ACE activity and found a marked decrease in that activity compared to captopril, and 100% of the patients in the continuation group required ephedrine after induction compared to the 18% in the withdrawal group, whereas captopril plasma ACE was reduced to a lesser extent, and about 64% required ephedrine after induction in the continuation group compared to 21% in the withdrawal. And so their main mechanism that they talked about was that Ang2 contributes to hemodynamic regulation, so inhibition causes peripheral vasodilation. And there's been, I think, some anecdotal experience with ARBs on our side of things that there's a thought that it's like harder to regulate hypotension under anesthesia, but at least for ACE inhibitors, they found ephedrine was effective in increasing the systolic blood pressure to above 120 in all of the patients. So they didn't need like vasopressin or similar drugs to have the same response. And then their summary was that ACE inhibitor use, specifically enalapril, significantly suppressed ACE activity and increased vasopressor requirements in these patients. Another reference to go through, so the title was a question, should Ang2 antagonists be discontinued before surgery? So this was also a pretty small group of patients, but it was a prospective randomized study of 37 patients on Ang2 antagonists for at least 3 months before elective surgery, and then group one that was discontinued the day before, and then group two was given an hour before anesthesia. They listed exclusion criteria, so chronic ACE inhibitor treatment on top of Ang2 blockers, renal insufficiency, and then severe heart failure. Um, this study found that systolic blood pressure decreased in the continuation group at 5, 15, and 23 minutes post-induction. That was statistically significant. Their episodes of hypotension were also longer, and there was increased need of vasoactive drugs in this group, compared to the withdrawal group. I did find this limitation like relevant. So in group one, they had increased use of calcium channel blockers and nitrates, which could have some effect of blood pressure and cause some bias in their results. And then a little bit of a propensity to develop hypertension in group two I think that was supposed to be flipped. Let me see. Yeah, I think that's supposed to be flipped because the withdrawal group had more episodes of hypertension in recovery compared to when it was given before. So sorry about that. And then there was really no severe postoperative complications that were reported. And so this is a table that I just felt outlined their like major results well. So when the Ang2 blocker was withdrawn in group one, there was like roughly one episode of hypotension, and like it was, statistically significant, but I think in the grand scheme of things, not too different in between the two groups. There's a bit more than like at least one episode of hypotension was more frequent in group two. Um, that had like more than one episode. Duration of episodes were a little bit longer in group two to get control of the blood pressure. And this is the study that these patients required terlipressin, which is similar to vasopressin, more so in the group that the drug was given prior to anesthesia. And then the hypertensive patients were more common in group one where it was withdrawn. But there was no statistical significance, but at least numerically different. So this is another piece that I wanted to delve into. So intraoperative hypotension increases the risk of 30-day mortality, and duration of intraoperative hypotension increases the risk of end organ damage. So there was two references, one of which I wasn't able to access, but this was a pretty large study that I thought had some nice takeaways. So this was titled Relationship Between Intraoperative MAP and Clinical Outcomes After Non-Cardiac Surgery. So they evaluated roughly 15,000 patients who had minute-by-minute blood pressure monitoring. They looked at MAP in different groups, but this was one of their main takeaways was that a MAP less than 55 resulted in the most significant risk of acute kidney injury. And so they did a lot of like logarithmic regression analysis to look at the duration of MAP below 55 and how that created like a higher odds ratio for the longer duration, which makes sense, but I think it's nice to see it stratified like this and in a pretty good cohort of patients. And so their hypothesis was patients randomized to ACE inhibitor omission would experience intraoperative hypotension episodes less frequently than those randomized to ACE inhibitor continuation. This is an overview of their kind of flow diagram of study design and participant enrollment. So they randomized a total of 291 and then allocated about 145 to continue ACE inhibitors and about 146 to omit them. And then they had some that were lost, like excluded or surgery was canceled. And so in the end, they had 137 in the omission group and 138 in the continuation group. So their study design was also prospective, randomized, and controlled. They talked about their randomization block, which I think was good that they listed that. So 1-to-1 in block sizes of 5 and 10, stratified based on age, and then they basically like enrolled them sequentially from a numbered list after they blocked them. Their serum creatinine was measured preoperatively and then postoperatively on day 1. And then they had some definitions that in like the meta-analyses that I were reading, like one of the limitations was there's a lot of variance in definition of just what like intraoperative hypotension is defined as. And so I think that makes it hard to draw conclusions when we have varying definitions. But for this paper, intraop intraoperative hypotension was defined as systolic less than 80, and then postoperative hypotension was systolic less than 90. And then hypertension was defined as greater than 180, systolic post-op. And then their study endpoint was hospital discharge, and then their blood pressure was collected every 3 minutes under anesthesia. They used the akin definition for AKI criteria, so an increase in creatinine by 0.3 or a 50% increase from baseline. Um, So for outcomes and statistics, their primary outcome was intraoperative hypotension occurring from the administration of the first induction agent through to transfer to the PACU. And then they looked at also postoperative AKI risk, and then hypotensive versus hypertensive episodes, cardiac events, and mortality. And they used the Fisher's exact test to compare categorical outcomes, and then the independent t-test or Wilcoxon rank sum test to compare continuous measures. In terms of their demographics, the ACE inhibitor that was most common was lisinopril, and then quite a few, like almost half of the individuals were receiving diuretics concurrently. Their preoperative systolic pressure was pretty similar in both groups at about 140, and then hypertension was the main reason why patients were on ACE inhibitors. Average age was also similar at around 64, and orthopedic surgery was the most common surgery that was performed in these patients. So main results were looking at vasopressor administration. So about 87% of these blood pressure drops under anesthesia required pressor support, and there was 171 episodes, less than 80 for systolic. There was about 80% of the individuals experienced this in the omission group versus 93% in continuation with a p-value of 0.02. And then they looked at also severe hypotensive episodes of less than 60, which was like not statistically significant between the two groups. I thought this was an interesting way to display their findings. So like the number needed to harm. So they said the patients needing to continue ACE inhibitors preoperatively to cause one additional episode of intraoperative hypotension was 7.5 patients. So I think it's just an interesting way to display that data. I thought this figure was a little bit confusing. I spent a lot of time trying to wrap my head around it just because like they're mentioning that the overall systolic pressure was below 80. quite a few times that they've noted, and I think this is like the mean blood pressure um, across all patients, and they have like a 95% confidence interval bar. But you can see that like in the ACE continuation group, none of the time points get even close to 80, even with the confidence interval bars. So I guess I was just a little bit confused, and I feel like the paper didn't like clearly state like why there was like discrepant information. Maybe I missed something, but yeah, I spent I spent some time trying to sort that out. So let me know if anyone else feels like that. Like maybe I'm missing something, or like, yeah, let me know if there's more clarity there. But um, so this table shows the episodes of hypotension was more statistically significant in the continuation group, so about 69% versus 55%, and then also significantly those that needed to be treated with vasopressors. And then they looked at also the duration. So like that goes back to the figure that like the more significant the severe hypotension, the higher theoretical risk for an acute kidney injury. So 7 minutes on average for the continuation group and 2 minutes for the omission. And then they looked at MAP as well, both of which were significant. And this is just more of like a visual representation of similar information that we just talked about in the graph or in the table. Um, and then, oh yeah, this was looking at like how soon after were these patients restarted on RAS inhibitors. And so in the continuation group, they're more likely to resume in less than 48 hours, like I guess like numerically, but not statistically significant. Um, and then the, let's see, post-operative hypotension, like we talked about, a little bit higher, less than 90 was more common in the continuation group. And then they looked at AKI and major adverse cardiac events and found no statistical difference between two groups, and no inpatient mortality was observed. So their discussion, they basically talked about confirmation of their hypothesis and that their study wasn't powered for postoperative outcomes, just for intraoperative hypotension. Um, and then they talked about like several studies that looked at mortality in relation to hypotension, and one mentioned that like the increased risk of an AKI increased risk of mortality was more significant when the blood pressure was less than 70 for 5 minutes. But again, like mortality hasn't really been shown for ACE inhibitor withdrawal or continuation in a lot of these studies. So I'll go through the two guidelines. So this came out in 2024 by the American Heart Association. And so they have this table that looks at recommendations for perioperative RAS inhibitors and find that if a patient has heart failure, um, then it should be continued for chronic RAS inhibition therapy. Whereas in patients that are on RAS inhibitors for hypertension, um, undergoing like higher risk non-cardiac surgeries, then maybe omission for 24 hours would be helpful to kind of limit the risk of intraoperative hypotension. And they don't stratify like ARBs versus ACE inhibitors in this guideline. They group them together. And then this is a study that also, I think the American Heart Association guidelines actually like was hoping would come out, I think, before they got published, but came out after. So this is the Stop or Not trial, published, I think, late 2024, and basically looked at like similar things, but had larger groups of individuals. And so is continuing RAS inhibitors before non-cardiac surgery associated with better outcomes compared to discontinuation? And they concluded that there's really like a similar rate across the board for all-cause mortality and major post-op complications. Um, in their particular population, they found 54% of the continuation group experienced intraoperative hypotension compared to 41% in the withholding group. So they calculated a risk ratio of about 1.3, but no difference in AKI was noted in these groups. And then this is the KDIGO guidelines that I believe came out in maybe 2024, I want to say. Um, so they actually recommend discontinuing ACE, ARBs, and SGLT2 inhibitors 48 to 72 hours prior to elective surgery. And they make like a statement that says like it's really important to obviously like restart these medications after the procedure to not lead to unintentional harm. And then they note the potential perioperative adverse events with these drugs and like the rationale behind considering temporary discontinuation before elective procedures. So I thought it was interesting to hear their strong evidence. I think, especially in light of the papers that are out there that really don't show an association with AKI. So I was kind of surprised to see that. And then this is a meta-analysis that will go through some figures that's more specific to ARBs. Like it looks at both ARBs and ACE inhibitors, whereas the prior study actually excluded ARBs. The PREOP-ACEI just looked at ACE inhibitors. Um, so eligibility criteria is pretty straightforward. And then they looked at both withholding and continuing these drugs. Their primary outcomes was all-cause mortality in MACE, and then secondary outcomes was AKI, congestive heart failure, and then CVAs. Looking also at intraoperative and postoperative hypotension, and then the length of hospital stay. So this was in their supplemental table where they were looking at the incidence of AKI with ACE and ARBs being withheld versus continued. And they actually found that it favors continuing compared to withholding and in their meta-analysis. And then for mortality, it's obviously like riding the line of one, so really no difference in odds ratio, which was, I think, consistent with what we talked about from prior studies. And then for major adverse cardiac events, um, overall pretty similar as well, close to one. And then intraoperative hypotension using ACE inhibitors and ARBs, they found favors withholding for pretty much most of the studies. I think a couple of them cross one. Um, yeah. And then there's
Hey, Allie,
two. Oh, yeah. Hey.
could you go back to that previous line?
Yeah.
Um, could you just clarify? Are you saying that the risk of intraoperative hypotension was more observed when it was withheld or continued? I just don't understand that. What do you mean by like what they mean by favors withholding or favors continuing?
I see.
Like, is this showing if the outcome is intraoperative hypotension?
hmm
Is it that the withholding is more likely versus continuing?
Yeah, that is a little confusing.
Or if are they saying that the better outcome is not to be hypotensive, so you're
Yeah.
they favor withholding to avoid hypotension?
I think it's the latter because they talk about like they calculated a 30% relative risk of increase incidence of hypotension by continuing the ACE and ARBs the morning of surgery.
Gotcha. Okay. Yeah, it was just a little confusing for the outcome, but that makes sense. Great. Thanks.
Mhm. And then for the veterinary side, there's two studies. One came out in 2016 looking at enalapril. There's really no study that I could find that looks at ARBs, but this paper was the effects of orally administered enalapril on blood pressure and hemodynamic response to vasopressors during isoflurane anesthesia in healthy dogs. So they used 12 female purpose-bred beagles. It was a placebo-controlled, blinded, and crossover study. So they had um, I believe at least a 1 week withdrawal between the crossover. So they gave oral placebo twice daily, or oral enalapril 0.5 mg per kg. for a week. And then that 15th dose was administered 19 minutes prior to anesthesia. And they found that the enalapril group had significantly lower average systolic pressures, MAP and diastolic, compared to placebo, as well as more minutes spent in hypotension and required greater number of interventions to correct. And it was interesting how they measured blood pressure in this study. They surgically inserted a pressure sensing telemetry device into the femoral artery of each dog. So I'm not sure why they didn't choose to do an arterial catheter, but like maybe it was eye cook related. I'm not sure, but um, yeah, that's how they measured blood pressure. And then there's a paper in 2007 looking at cats that found pretty similar studies um, to this group, except they administered the drug 3 hours prior instead of 90 minutes. And then this is one of the figures in this study. And they, so they have on the x-axis blood pressure parameters and on the y blood pressure at end tidal isoflurane. This graph isn't well described because I think like, is it like in the paper they talk about AT50, AT15, which is 15 minutes after the end of end tidal isoflurane is reached, and that's how they describe this graph. But it could have been like AT0. Like I just don't think it's clear like the time frame, and so I think it would have just been nicer to say that in the figure notes. But they compared the statistical significance between placebo, which are the clear dots, and then the black dots are continuing enalapril. They don't find any statistical significance between the withdrawal group. They did say in the discussion they suppose that like a 12-hour withdrawal group for enalapril like might have not been enough, and I think that holds true at least on the human side. Like there's a 24-hour withdrawal before they test this, so it seems like there was a similar trend between the withdrawal and the continuation group. And so maybe it would have looked similar to the placebo for the withdrawal patients if it would have been a longer withdrawal. Yep. So those are my references, but I wanted to kind of hear from everyone as to like what they're doing in regards to these meds and yeah, what the thoughts are overall.
Thanks, Ellie. That was great.
Yeah.
And for clarification, I think the KDIGO guidelines might have. I think they came out before that that large study that you also cited that showed that there was no difference between
Hmm.
the groups.
Oh,
Um,
this one.
yeah, exactly. I think the KDIGO guidelines were published before, and certainly those guidelines are usually a long time in the making as well too. So oftentimes like the evidence cutoff is even a little bit before those are published. Then like they might even cut off like 6 months or a year before it is actually published because it's just so much work for like the consensus guidelines to take effect. So I don't think KDIGO includes this JAMA article.
Mm. Yeah, that makes sense because it's published probably around the same time that they came out. Yeah.
Yeah, yeah, exactly. Well, this is interesting because there's certainly been some discussion in our community about the use of ACE inhibitors or ARBs prior to anesthesia, and internally at Friendship, we've discussed it in our team because some folks have suggested that they see this refractory, like intractable hypotension that cannot be managed in patients that are receiving telmisartan, and that was just not something that was, I think, on any of our collective radars. And I think we do generally recommend stopping 24 hours before they have a procedure, but I wouldn't be surprised that some of those patients did get it before. And so I'm curious to see how often people might be running into that. I didn't get a sense going through this paper, or certainly from your citations, Ali, if you had seen other mentions of like a severe unresponsive hypotension that was observed in patients, and if it was more frequent um, in these patients getting RAS inhibition. I mean, certainly they use a lot of vasopressors, which is, I think, interesting that even the patients that had withdrawal, you were still looking at like 45% of patients that were being put on vasopressors during
Hmm.
anesthesia, which is probably more than our, for if you look at the same patient population, this is like orthopedic and spinal patients, like maybe some of our spinal patients, but probably most of our ortho patients are not requiring pressors during it. So, that's
Hmm.
certainly one difference, but it seemed like the difference was like 2 versus 7 minutes. It wasn't necessarily like 2 versus infinity minutes of hypotension.
Yeah, I think the only thing that this paper brought up was that the patients that received ARBs prior to anesthesia were the group that required terlipressin in addition to like ephedrine or dopamine. Like they required a like vasopressin agonist, where I don't feel like that was a consistent finding like in other studies that included ARBs, and it didn't seem like it was a finding with ACE inhibitors alone. But it's not like it was irretractable, like using everything that they had in their arsenal, like the patient's like blood pressure eventually responded.
Is that anything others have observed? Alan, did you get a sense of how often the studies were randomized as to which patients had their RAS inhibitors uh, discontinued before versus was it just opportunistic sampling?
They were randomized in a block, and it was like sequentially. So it truly was randomized and opportunistic.
And was that true for a lot of the other studies that you shared as well too?
I'm trying to remember. I can't remember the methodology of this one, but I know the pre-op ACE inhibitor one was. I'd have to look back on like the specifics on randomization for these other ones. Yeah, I didn't
Gotcha.
include the how they randomized, yeah, for both of these.
Okay. And then the other comment I had is when you look at the indications for so many of these patients, they're really getting RAS inhibitors for hypotension, where sure we might use these drugs for hypertension, for hypertension in our patients as well too, but I think we are probably collectively dealing with a different patient population. It might be like our proteinuric CKD patients that need to get a dental or something like that, where maybe their blood pressure is normal, maybe not, maybe they are hypertensive, but certainly our patients get hypertension for much, much different reasons and than people where just being hypertensive is a primary disorder secondary to underlying cardiovascular disease. So it is a bit of a different group, certainly, that our patients are getting it for problems that are not due to arterial stiffening and things like that that they're seeing in people. And I guess I wonder to what extent that might play a role in the outcomes that are observed. And certainly, 12 healthy beagles probably don't represent anything when it comes to a patient who has uh, clinical illness that we're managing. So I wonder what differences those might actually end up having an effect in the real world.
Yeah, yeah, that's a good point. I think it's hard. I just wish we had more data like on the veterinary side because I think it's really hard for us to make decisions off of what there is and on the human side.
Right. Is for the everyone in the audience, is that standard therapy that people are recommending that they're stopping RAS inhibitions prior to elective procedures, or is anyone maybe just not not thinking of it and not necessarily making that recommendation to people.
There's one in the chat that says we stop ACE inhibitors before GA for the past 5 or 6 years.
Hi,
I think
everyone.
Steph.
I'm Alice. I'm the one who just put that in the chat. We stop usually ACE inhibitors 24 hours before GA at least. If like it really depends on the case and what kind of disease they have. But we managed to educate the surgeons as well to do it. So yeah, that's what we've been doing, but would be very interesting to look at our data retrospectively and see if it changed anything in terms of outcome. Thank you very much for your presentation, Alyson.
Yeah, absolutely.
Yeah, it would be nice to uh, see if there's some type of surgical intervention that would be common enough, or maybe even like a dental cleaning, where maybe you could retrospectively look at those patients that had received ACE inhibitors or an ARBs uh, prior to the dental, and you could certainly subgroup them as those that were withdrawn versus those that had them continued, and then compared that to patients who were not receiving them to see what the frequency of hypotension would be. Now, granted, those can be very, very different patient populations. You know, a healthy dog getting a routine dental prophy versus a patient with kidney disease, that maybe we wait until they're also having a bit more severe dental disease to really take on the risks of anesthesia. But there might be, the data is probably going to be dirty, but there's probably something in there that you could tease out some information to see what might be present.
Yeah, and I think it'd also be interesting to see like how their kidney values trend and how they do post anesthesia as well to try to see like do these patients develop AKI if they like have intraoperative hypotension? Like it seems like that's not the case on the human side, but I think it'd be interesting to see if that's also not the case in our patients.
Yeah, which is kind of the ultimate point, right?
Hmm.
If they don't have any difference in AKI or change in mortality, but they have more intraoperative hypotension that requires more intervention. Okay, it might be a bit more of a pain in the butt to manage them, but um, is it does it really matter? I guess
Yeah.
that's the
Yeah.
question.
Yeah, or
Um,
even like looking at biomarkers too, because it's like, is creatinine the best surrogate for that? If it's like a brief episode, I don't know. Maybe not.
yeah. And Steph had asked, if you have clients that then forget to withdraw the ARB or the ACE inhibitor, do you reschedule it or do you just have them go forward with the procedure? What's everyone's take on that? Personally, I would probably just still do it. I doubt I would have them come back in another day, but I'm curious to see what everybody else is doing. I think maybe Steph had a patient that she booted for a procedure in the last month or so because they got their telmisartan that morning.
I think that was actually my patient, maybe.
It was Ray. That makes more
Yeah.
sense.
But the dog was azotemia and was getting a renal
Definitely done
biopsy.
that.
Okay. Yeah. I still think I probably would have personally have gone forward with it.
And
Um,
and they weren't at the hospital yet. It was like 6:30 a.m.
okay. still think I would have gone through with it, but that's okay. I mean, that's difference in opinions.
Oh,
Paolo
that's
said that
interesting.
he's rescheduled a few because anesthesia didn't want to do it, which is I
Mm,
think maybe where some of the conversation has initially started is with some anesthesiologists that were like, maybe that's where some of the um, the opinion of like this intractable hypotension was coming from, and I don't think our anesthesiologists at Friendship really necessarily care all that much, or certainly haven't really approached us with it. Um,
the Kim one is interesting. Like Alice was saying, she's done some studies in cats under GA and how like Kim one was really high when they had hypotensive events. Hmm, interesting.
Processing as well too.
I had specifically asked our anesthesia if they cared about processing, and they said they didn't.
Here, Ray?
Yeah, I had asked like if we were potentially going to do a sub, if I should just not start it, and they were like, "No, we don't care if they go
Hmm.
gotten it."
Yeah, it's interesting how different the opinion is overall.
Alice, are you asking, would you still pursue a procedure if they were on an ACE inhibitor versus an ARB? Is that like if they still took it that morning, would we still move forward? Is that your follow-up question that you were asking?
Yeah, sorry, there was a typo in there. I'm asking if, because we're talking a lot about, like, we're talking a lot about ACE. Would you approach the case differently if they're on ARBs, or did you answer all these questions based on the fact that it would be either or ACE or ARBs?
Yeah, personally, I would look at it as either or, but in all honesty, probably 98% of our patients are going to be receiving an ARB rather than an ACE inhibitor. Um, Probably cardio still uses ACE inhibitors, and I think we might have a few random patients that still get an ACE inhibitor because they just have GI intolerance to telmisartan. But otherwise, I would say the vast majority of our services patients are going to be on ARBs rather than ACE inhibitors. All right. Well, it seems like based upon the human evidence and kind of what we're doing, seems reasonable to recommend discontinuing 24 hours beforehand. The evidence that giving them an ACE inhibitor and ARB prior is maybe not that strong that it's associated with significant long-term outcomes or morbidity, but you might see more frequent or more prolonged hypotension, which uh, you could argue how much of that could be clinically relevant, but potentially be prepared to see maybe a little bit more.
Yeah, I think that's a good summary. Alice just said vet literature, as the vet literature is scarce on this subject, do you think a randomized prospective study on patients under GA would be reasonable, withdraw or not? Yeah, I mean, I think that would be ideal. I think it'd be like for our hospital hard to find enough patients on ACE inhibitors to do that. But yeah, I don't feel like Yeah, I mean, I feel like it could be done with how many patients we have on ARBs to like enroll them and randomize them.
I think you can do it based upon the 2024 JAMA paper. I think
Mhm.
without that paper, and I think I think that, yeah, what Alice is asking, like, I think everything else would point to that probably not passing IACOC review if
I
the
see.
standard of care and studies that had shown more negative outcomes were associated with withdrawal. It might be harder to do. But I think the 2024 JAMA paper that showed that there wasn't a difference then brings everything into question. Well, are they small patient groups? Are there heterogeneous effects? And so I do think that based upon that, you can use it to say, listen, the evidence goes in both directions, and so it's really hard to be definitive, and we need more research to answer it. And I think that's true in people, and certainly it's out of we don't have anything other than experimental models in our patients. So I would say personally, I think it would be ethical. You would just obviously need to have a well-defined rescue protocol for hypotension to deal with both patients that are withdrawn and patients that are continuing it, just to have that safety plan essentially laid out for them. But I think you could justify it. And I personally wouldn't see it as an unethical study based upon all the data that Ali has shared so far. Well, that was really great, Ali. Thank you for that. Any other final questions or comments or anything anybody else would like to share?
Thanks, everyone.
All right. Thanks, Ali.